either skeletal or adults, due to either skeletal problems or growth development problems due to larger tongue, small teeth, big teeth, small face, whatever the cause is, just cosmetics. But obviously the long-term goal is to facilitate fix cosmetics, but also function of some teeth, getting them in the right place, and also it makes keeping the teeth clean easier. If you've got teeth that are all crowded, it makes it tough to get in between all those nooks and crannies, get in there to floss. If the teeth are crowded, there's less bone between the teeth, so gum disease, once it starts, because there's very little bone, it progresses faster on patients that have crowded teeth because there's not much bone there. You want nice dense bone between the teeth, and that way it's a little bit more resistant. So again, orthodontics is the dental specialty which focuses on growth and development of the dentition and its surrounding anatomical structures. The specialty deals with the prevention and correction of dental and oral deviations. Orthodontists limit their practice to the correction of malocclusion and the straightening of teeth. Okay, so what's malocclusion? Just a bad bite. Malocclusion, bite, so malocclusion. Okay. So there are some different things that can cause this malocclusion. Okay, and some of the things, it's nothing that the kid did, nothing, it's parents' fault. Okay, and it's genetic. Okay, it just comes down, came along with a package. So more than likely, if your parents had a big gap between your front teeth, there's a possibility that one or two of your kids will end up with a big gap between their teeth. Or if the parents had large teeth, more than likely kids are going to have large teeth and small bone structure, so they end up with crowding. So again, jaw and teeth discrepancies. Okay, either the jaw's too big, the teeth are too small, or the teeth are too small, the jaw's too big. Whatever the case may be, there's discrepancies between the jaw and the teeth. You can have facial and palatal clefts. Okay, I think everybody has seen patients that have, either a palatal cleft lip, but sometimes those are cleft palates. Okay, that now you can see it on the outside, but there's malformation of the palate where it didn't completely close. Okay, so they could be missing teeth, there could be a gap, and some of the time orthodontists and oral surgeons get involved in those cases, again, so that the child can kind of have a good childhood and not get picked on, and it just all kinds of self-esteem problems with those cases. Again, large or small tongue. If you have a very big tongue, what's it going to do to your teeth? Push them out. You can have a very broad lower jaw. Maybe your upper jaw is narrow, because your tongue is pushing things out, or your tongue may push teeth forward and you can have flare teeth. Okay, so again, and this is all genetic. Development of muscles and frenum. Again, really strong muscles. Again, you see these patients that come in with kind of a square face, and they're kind of short, stocky, men usually, and their facial muscles are just keeping everything nice and tight. Okay, or their tongue is too strong, or muscles, tongue frenums are pulling on the teeth back, or the lip frenums are pulling, and again, that just causes disruption of all the teeth and their positioning. Okay, so know those four there. Discrepancies, clefts, tongue size, and muscles and frenum development. Okay, again, those are genetic problems. Things that are systemic, okay, that run throughout the body. There's infectious diseases, endocrine disturbances, and nutritional disturbances play a role in how the teeth develop and function. For instance, a high fever during development can affect the tooth bud formation, causing malformed teeth. So if while your baby's forming, you have a high fever, or maybe the baby has a high fever, soon after birth, when the teeth are still in their developing stages, the cells that are forming at that point could be damaged. So the cells that were making the tooth size at that time would have stopped making the tooth. And then once the child gets better, then it continues, so it's going to disrupt the size of the teeth there. So when they erupt, instead of having a tooth that's kind of, the proper shape, it may be straight up and down. And if your skeletal structure is such that the ideal teeth would have been like this, but now they're straight, again, you're going to end up with some gaps. Okay, so those were systemic problems. Local oral problems, things going on inside the mouth. Again, this is a big one. I just have a case, and I'm having to bring a patient back. I saw a case Wednesday, I think. I'm thinking, yeah, you guys were here for that. Anyway, the patient came in for an initial exam, took bite wings, and he's missing one baby tooth. He's already got a 6-year molar. His 6-year molar is drifted all the way forward to the other baby tooth. So we take a Panorex. He's actually got an impacted second premolar because they took out that tooth. The mom said, "Oh yeah, he had a tooth bother him, a few years ago, and the tooth was taken out." I said, "Well, they didn't recommend a space maintainer." "Yeah, but we never went back." I said, "Well, now there's a big issue because that permanent molar is completely tipped this way. The permanent premolar is underneath." And actually, when we took the Panorex, there's actually a supernumerary tooth, or an extra tooth, underneath there as well. Okay, so once I saw that, I called her. I need to get her back because she's probably going to need surgery to get that tooth out. So there's more than one thing going on. But early or delayed loss of baby teeth, if it's an early loss and nothing's done, again, things are going to change. Your permanent teeth are going to drift, or you're going to have delayed eruption of the permanent teeth because that baby tooth was lost early. And again, permanent teeth kind of guide themselves on the roots of the baby teeth. They kind of eat away on the baby tooth, and then finally the root is resorbed and the tooth comes in. Well, if that tooth is lost first, then that permanent tooth ideally kind of guides itself on those roots, and it doesn't. It may have more trouble, working its way through the bone and through the tissue till it comes out. So it may be delayed in coming in, which may cause some other problems or drifting of other teeth. If you have early eruption of permanent teeth, okay, if the 6-year molar comes in before the second baby premolar for whatever reason, if your canine, which should come in at age 11, kind of beats the eruption of your premolars, which should come in around age 10, 9 to 10, then it kind of disrupts the order of the bite, and it's going to cause some shifting and moving on how the teeth finally end up positioning themselves at the end there. So this is not as common, the early eruption of permanent teeth, but I have seen it where the canine is ahead of the premolars, and normally your premolars should be ahead of your canine, or you get your 6-year molar in early. Early loss of permanent teeth, and this, we see either with teenagers if they lose their permanent molar early because they didn't brush, or mostly in adults. If we end up losing a permanent tooth and the patient says, "Well, it's in the back, I'm not going to do anything," well, what's going to happen? You're going to get tipping. And that doesn't happen overnight, and that's usually why a lot of patients kind of put it off. But over time, the teeth where the space is created will tip in. You have a tooth up above that now doesn't have its partner to bite down on. So what's it going to do? It's going to start to drop down. Okay, so you got teeth tipping, teeth dropping. What does that do to your bite? You know, your bite kind of has to find a new way to come together over time. Ends up causing, you know, not just bite issues, but gum problems later on as well. So early loss of permanent teeth also causes a problem with your bite. Gum problems. Okay, if you end up with gum problems, again, you end up with loose teeth. Teeth begin to flare or move. If you don't have the supporting tissues, the supporting bone to hold teeth in place, you're going to have movement of teeth. Cysts, and when I think we've shown those pictures of a cyst or bone growth underneath that causes teeth to move. Okay, a cyst or an abscess that starts putting pressure underneath the tooth is going to cause a molar, you know, to tip, or if you have some sort of bone tumor growing underneath, is going to cause, you know, teeth to move as well. Trauma. Again, I've got a patient I just saw in yesterday, I think Tuesday. Wednesday. He's worn a flipper. A flipper is like a little removable partial denture. Just it's not metal. It's just all acrylic. He's missing 2 teeth. Fell when he was young. This guy's probably 40, in his middle 40s now, and he's worn this flipper for years and years, and he's asked about doing something else. Just never has. And actually, I'm making him another one because the one that he has right now already broke. But he broke these 2 front teeth. A volts are knocked out, the lateral and the canine on the left side. Plus the 2 in the middle, right now they're broken and they're in. So when he bites down, he bites edge to edge, not ideally. But he's never done anything, and he's worn them down and chipped them down. The only way to correct that is he has to wear braces to flare those teeth out so that I can fix them, because I don't have any room to fix them. They're edge to edge. I can't add anything because he's just going to bite down on my filling and break it again. So it's got to be moved out by braces so that I can fix them. Okay, so trauma will also cause these problems. And this is another big one, thumb sucking and tongue thrusting. Again, we talked about the tongue earlier. The tongue is a big one that pushes teeth out. Okay, and you've probably seen or heard people that are tongue thrusters when they talk. Okay, so again, some pictures here. This baby tooth, this is how it's supposed to go. You've got the baby tooth, the permanent tooth comes right in underneath it. So this is holding the space for that permanent tooth. And patients will always say, well, let's just take it out, it's a baby tooth. Yeah, it's a baby tooth, but if you take it out, then we've got to do something to hold that space. If we don't, you're going to have major issues like this other kid that I saw a couple days ago. So this is kind of what it's worse than this one, what I saw. This is just the model, but again, this here you have the permanent tooth developing, and the 6-year molar is coming in, and on my patient, I mean, it's already here. And so this guy's locked down underneath, nowhere to go. They've actually got another tooth down here, it's on top, but down here developing, that's an extra tooth that shouldn't be there, but we just found it on the x-ray. So she's got major issues. They're going to have to push, and it's a lot harder to push this tooth back now because you've got the 12-year molar behind it, and it's kind of up in this area right now. It's got the 12-year molar. You've got to push those teeth back. It's a lot harder to do that and more expensive than when you lose that baby tooth. Put a little wire space maintainer there to hold it. It's going to cost you maybe $200 to make that and cement that. You're going to hold on to it for 3 or 4 years, and then this tooth comes in and breaks right through. Or it's going to cost you, probably $2,000 to push those teeth back. So early loss of baby teeth mesial tipping of the first molar, impaction of the second permanent premolar. Okay, again, you lose a permanent tooth and you get drifting. And then if your tooth up here is going to drop down into that space. So what's going to happen in here?
It's going to be more loose, like more space.
You get more space. Yeah, it's going to continue. It's going to tip. But what's the problem in this area versus this area? What's going to happen in there every time you eat?
It's gonna get stuck in there.
Food
So it's
impaction.
going to decay.
Yeah, you're going to get food impaction. You're going to get cavities here. And again, it's just a domino effect. So what are habits that influence the development of teeth? Again, thumb sucking is the big one. Prior to age 5, there's usually no permanent defects, okay? And that's depending on who you read. But usually younger kids, you know, age 1, 2, 3, you know, it's just kind of a comforting method that they use to go to sleep or whatever. Or sometimes throughout the day, that's the biggest one. If they just put it into sleep, but, you know, if it's throughout the day, it's causing some damage. But little kids, it's usually not that bad. So what will happen? It's just going to make the anterior teeth flare out and kind of arch and vault the upper palate. Tongue thrusting. Again, these are patients that when they swallow, as they swallow, instead of their tongue going to the roof of their mouth, when you swallow, I think none of you are tongue thrusters, you may swallow, your tongue goes to the roof of your mouth to seal, and your tongue kind of pushes everything back, kind of like this little dance there, kind of pushes everything back as you swallow. But a tongue thruster, their tongue, instead of going on the roof of their mouth, goes forward and on their front teeth. So when they swallow, they do this, and they swallow. So again, the tongue is really forceful and pushes those teeth out. Bruxing is grinding. Okay, clenching, grinding, that's called bruxism. And it's usually involuntary. I mean, you don't grind your teeth just because you want to. But again, what's this causing as you clench and grind? It's causing wear of your front teeth. Like that patient, obviously he didn't put his teeth edge to edge on purpose. He broke them into that position and they were just left there. But over time, he's just kind of wearing them and grinding them and clenching on them, and the teeth are just getting shorter and shorter on them. Mouth breathers, again, can cause facial distortion due to the narrowing of the dental arch. Again, if you're a mouth breather, your tongue isn't in the right spot. So if your tongue isn't in the right spot, what's causing, it's going to cause, you know, the arch to come in. If you breathe through your nose, your tongue is down, your tongue is keeping that space. If you open your mouth, your tongue is not in the correct position, so it narrows the arch. Again, the tongue is a muscle and kind of balance things out between the cheeks and the gum. On older patients, we see this. As patients get older, you know, early, 70s or so, they'll start to see that their teeth kind of start to flare. You know, and I've seen it on my patients. I've got patients that I've closed the diastema, or the space between their front teeth, just with a filling. And after 2 or 3 years, that my fillings they had contact are separated. And I used to ask myself, why? I know it wasn't like that. Well, what's happening as they get older, your facial muscles, what happens? Yeah, just like everything else. You know, your facial muscles get weaker. Just like, yeah. What's that? Yeah. Well, it's true. And so if your facial muscles aren't as strong as they used to be, your tongue may be a little bit stronger than those facial muscles. You'll start to push those teeth out. And that's my only explanation. And I've kind of talked to orthodontists, and that's what it is. But a few years ago, it's like, man, I know this thing wasn't like that. Why is it moving? Well, that's why it's moving. But clenching and grinding can also wear these teeth down. And as you wear the teeth down, they get narrower. so they can cause some space as well. Again, at this age, we probably don't worry too much. Okay, they just like to do that. At this age, we may start to worry a little bit more, because again, as you suck, you're pushing that thumb up into the palate, and you're kind of pulling those front teeth forward. You end up with the buck teeth syndrome there. And again, it's kind of a self-esteem issue. Once they get into school, they'll get picked on, and again, we want to break that habit, not just for them, but also for their development. And this is what's going on. You've got the tongue, you're kind of flaring these teeth here, and you're pushing that up in there, kind of lifting that vaulted palate up underneath the nose, which is also going to could cause some breathing issues, congestion, allergy type of syndrome, stuff like that, because you're just compressing everything underneath the nose there. And you end up with this. Okay, this also poses a problem when teeth are flared out. And what do you think that would be? The teeth are flared out in the arch. They're more prone to trauma. We see a lot of kids that come in, and because they're thumb suckers, they hit themselves on the door or something. Well, what's out in front? Their front teeth. And we see a lot of kids that break their front teeth that are thumb suckers. So, there's a whole bunch of things that can be done. Some are a little barbaric there, but, you need to do what you need to do to hopefully try to break that habit. Hopefully just positive reinforcement on a child as they're doing their habit, and you try to break it away. And hopefully, but if nothing works, there's those little baskets that you can put up there, and they have little prongs there, so when you put your thumb there, it pokes your thumb. There's these things that you can buy, these usually they find a way to take them off. They just suck over them.
Where do you buy those at? Where can you buy those at?
Do you suck your thumb?
No, my son does.
Does
You just like it.
Oh, yeah.
My brother's
No, he sucks his thumb, but only at night to soothe him to go to sleep, but just for a few minutes, and he's out. Like, he doesn't do it every day or like during the day.
Yeah.
He'll just do it at night. And I'm trying to get him
Now,
off it.
is it cause, how old is he?
3. But he's been doing it for,
Yeah,
One,
it may be something that will break. I mean, again, at that age, it's probably not
yeah, he's
really
doing
that
it still,
issue.
but I'm still trying to do it
Yeah.
now before.
Yeah, start
he gets to
reinforcing
it.
him little by little. Start
says-
reinforcing him.
My brother sucked his thumb till he was 10 years old, and his dad sucked his thumb till he was 12. So
Yeah.
it's like, but they don't have anything wrong. Like, nothing.
Not
There
every-
was nothing.
That's a good point. Not everybody will develop. They'll.
His dad didn't even have to have braces.
Yeah.
It was crazy.
Yeah, again, everybody's different. They may just have real dense bone and nothing moved, but most kids will end up with some deformity.
No, I've never seen that before. It was weird.
So this is a tongue thruster. Again, it causes sort of the same thing, kind of a buck teeth. And again, when they swallow or sometimes when they speak, that tongue comes and forces its way through those front teeth. This is an appliance that can be put on those tongue thrusters to try to make them learn the habit of putting their tongue on the palate and not up here on the teeth. Okay, so you're trying to re-educate the tongue. And it's not only re-educating the tongue, you also have to get involved with a speech therapist for these kids, because they'll usually have some speech impairment as well. Okay, so we may make a referral to a speech therapist or somebody. Again, here's another kind of nasty looking thing, so that your tongue doesn't go in there. If it goes there, you want it to go up on the roof of your mouth and not on your front teeth. So you try to put some hooks there so that it doesn't like it. may or may not work. Some they'll find a way to work around it sometimes, but over time, hopefully it does work. Clenching and grinding, you'll see kids that come in, and I mean this isn't too bad. I've seen kids where you can barely see the teeth. I mean they're almost under gum tissue.
Yeah, that's
They
what
just
I got.
clench and grind.
Teeth are tiny.
Yeah.
And she lost them like this big.
Yep. So they'll just grind and grind and grind, and really at this age, there's nothing you can do. I mean, you can't put a night guard, you can't put anything to prevent it, because things are changing, and compliance is gonna be terrible. So, you know, one of the things that's being lectured on right now is kids that do this, usually have some, airway problems. So if we see this, we refer out to the ENT, so that they can check for large adenoids, because this seems to be a reflex of it's kind of like sleep apnea. So they kind of don't get the oxygen they need, and it's a reflex. So when they go to get oxygen, they grind their teeth. And studies are showing that the cognitive development, the learning of these kids, is lower than kids that don't do this. Because again, they're not getting a good night's sleep, and this, I mean, it may not be every kid, but studies are showing that some of these kids that have this airway problems, their cognitive development is lower than
So
somebody
would it
who
show when they get their adult teeth too, or?
Not
just
necessarily. Not necessarily. Again, it's a habit that usually will not appear on when the grown-up teeth come in, but if it is an airway issue, it may, you know, and so they'll be sent to the ENT, and they'll check, they'll maybe do a sleep study on them and see how they're sleeping and what's causing, and usually, and that, what they're finding.
Yeah.
Yeah, he took that course, I kind of learned from him. But they're, again, it's just a reflex of they feel like they're not getting the oxygen, so they just grind their teeth to wake themselves up, and then it kind of goes away. So occlusion, and this is the way teeth come together, is your occlusion. Malocclusion is just a bad bite. Okay, so occlusion, malocclusion is a bad bite. I think there's a test, or test question on malocclusion. It may come up, but know what malocclusion is. The entire form and function of the face and its structures are directly affected by the manner in which the biting surfaces occlude or come together. The development of occlusion is an ever-changing process that continues throughout life. Again, I just talked about a few things again on how the bite can change. One is clenching and grinding. As you're getting older, you know, your teeth change, your bite change. Or again, as we get older, our facial muscles or other muscles deteriorate, and your bite changes because the teeth are going to move or flare out. Okay, so it's an ever-changing process. It's not you get your bite when you're 16 and that's your bite till you die. No. Okay, it's always changing. Wear, loss of teeth, you get a filling. What happens when you get a filling? Your bite changes. I mean, we're doing stuff to your, you know, you try to get it the same, but it's not the same. You know, we're doing stuff. So what is ideal occlusion? Okay, what is the perfect occlusion? So the ideal occlusion is the maxillary teeth are in maximum contact with the mandibular teeth. When in maximum contact, there is a 2 millimeter overlap. Okay, meaning like this, 2 millimeters overlap of the maxillary anterior teeth over the mandibular teeth, and maxillary posterior teeth are one cusp up to mandibular posterior teeth. Okay, so if you remember your guys' models, if you put those models together, that's your ideal occlusion then. You've got your front teeth have a 2 millimeter overlap, and then on your upper back teeth, there's one cusp on the outside of your lower teeth. Okay, so kind of like this. You got your 2 millimeter overlap, and then your upper cusps are on the outside, one cusp on the outside. If they're reversed, then you have what's called a crossbite over that. Would be your ideal occlusion. Okay, something like that. Okay, that's ideal. Ideal. Malocclusion would be, you could have this tooth behind this one, you have a cross bite, you could have an open bite, you could have posterior cross bite, all those would be considered malocclusions. This is ideal. I mean, this is not everybody has this. I wouldn't say. This is how you want your contacts to be on the outside cusps of your lower teeth, central in the center of the molars if you can, and on the inside cusps of your upper teeth if you can. This is what we're trying to achieve when we do crowns and restorations. You want dots like that. You don't want big smudges. Okay, centric occlusion. So maxillary and mandibular jaws are closed. The teeth are in maximum contact, okay, so kind of ideal bite, and the heads of both condyles are in the most retruded, unrestrained position in the glenoid fossa. Okay, so which head of the condyle is in the glenoid fossa? You've got two heads in the. You've got two heads. You've got the coronoid and the condyloid. Okay, so the condyloid head is going to be in the condyle of the glenoid fossa, in the most retruded, unrestrained position. So again, this is going to be kind of in a relaxed. The teeth come together, and it's back there, and that's what we call centric occlusion. And that's usually what we try to set our models when we work on anything. We try to put all the teeth together because you don't want to build a crown if the bite is open. You want it, where all the teeth come together, ideally. Okay, so malocclusion, we talked about any deviation from the normal pattern of occlusion, whatever it may be, it's a malocclusion. It's not ideal. I mean, you get a patient who's got that, and they say, it doesn't bother me. I mean, it's ideal for them, but technically it's a malocclusion because they've got a crossbite or underbite or overbite or whatever. So what does it do? It could impair chewing or mastication. It could increase the susceptibility to caries, as we talked about, because you can't clean between all these crowded areas. Increase the incidence of periodontal disease, again we talked about, because you're going to have minimal bone between these crowded teeth, and in addition you can't keep them clean, so it just makes things worse. Can lead to early loss, again because of the crowding, possible early gum disease. And again, we talked about respiratory habits. It can affect self-confidence in relation to facial aesthetics. Okay, we talked about that as well. Self-esteem of kids because of, their appearance of their teeth. Not just their teeth, I mean their chin growth or their upper jaw growth. And again, they could impair the speech. So these are the things that malocclusion can do. Okay, so what are the classifications when you go to the orthodontist? These are the things that they look at. The Edward Angle classification based on maxillary and mandibular first permanent molars. Okay, so this is what they use to classify how teeth are, or how the occlusion is set. There's a class 1, and that's what ideal would be, a class 1 occlusion. The profile of the patient is called mesognathic, meaning it's straight. As you look at somebody that from chin to the just underneath the nose to the forehead, so forehead underneath the nose and chin, it should kind of be a straight line, almost. I'll show a picture. The occlusion is neutral. Molar relationship, mesiobuccal cusp of the maxillary first molar is aligned with the buccal groove of the mandibular first molar. Okay, so kind of picture that. The mesiobuccal cusp of the maxillary first molar is aligned with the buccal groove of the mandibular first molar. Okay, so here you go. Mesiobuccal cusp of the first molar is aligned with the buccal groove of the mandibular first molar. And again, if you go from here to here to here, it's a fairly straight profile. Okay, so that would be mesognathic, class 1. Okay, neutral occlusion, mesiobuccal cusp of the maxillary first molar, aligning. Do you guys have these pictures?
Yes.
Yeah.
Yeah. There, I don't know if I got it yet. Okay, so class 1, again, here, this is your ideal occlusion, mesiobuccal cusp, and it comes right down on that buccal groove of that mandibular first molar. Okay, class 2, retrognathic, kind of me. I'm retrognathic, I've got a weak chin. Occlusion, distocclusion molar relationship, mesiobuccal cusp of the maxillary first molar is aligned between the mandibular second bicuspid and the first molar. So the mesiobuccal cusp of the maxillary first molar is aligned between the mandibular second bicuspid and the first molar. And there's a division 1, anterior teeth are overjet in maxilla, and then there's a division 2, the maxillary centrals are depressed, kind of back like this. So you have the laterals and the centrals are back. That's not too important. So again, if you look at the profile, it's retrognathic, meaning the gnathic means jaw. Okay, so retro means back. So again, if you draw this, you're going to kind of be in a curve. Okay, and so your lower jaw is back. Here you got the mesiobuccal cusp is in between the second premolar and the first molar. Okay, instead of this cusp being back here, it's kind of one cusp forward, meaning your jaw is back. Okay, again, the mesiobuccal cusp is the line between the mandibular second bicuspid and the mandibular first molar. Okay, in class 1, this cusp is back here. And you can see you've got more space between the lower jaw and your front teeth. Okay, so you're more like this. Instead of being like this, ideal, you're like this. Okay, again, here's the mesiobuccal cusp between the first premolar, or the second premolar and the first molar. Okay, this cusp should be back here where this cusp is. And you can see the overjet, or the space that kind of gives you this. You can see this profile here versus after treatment, that profile there. You can see that change. Class 3, prognathic. Yep. Kind of Jay Leno type of deal. Bulldog appearance, they call it. Again, mesiocclusion, the molar relationship, the mesiobuccal cusp of the maxillary first molar is aligned between the mandibular first and second molar. So now it's on the back side of the first molar. So here it is, the mesiobuccal cusp, instead of being here where it's class 1, or here where it's class 2, it's back here where it's class 3. And most of these guys, I mean, the lower jaw is on the outside of the upper jaw. Okay, so you've got an underbite. Okay, you've got this kind of a profile, and that's kind of what it looks like, skeletal. here's the, he's missing a tooth here, but if this was the first molar, again, it's behind the first mandibular molar. Again, something like this, and after correction or orthodontic, he still has kind of a, you know, class 3 profile, but you can see how much better that. Okay, malocclusion conditions. Again, class 1, class 2, or class 3 deal with the overjet of your anterior teeth. So the horizontal distance that exists due to protrusion of the most anterior maxillary incisors to the facial aspect of the most anterior mandibular incisors. Okay, so how far your maxillary teeth are in front of your lower front teeth. Okay, so it deals with this. The overjet is this horizontal distance from here to here. So we would measure, if a patient comes in with this, I'd put my perio probe and measure from here to here, from edge, incisal edge till I touch the tooth, and say 10 millimeter overjet on teeth number 8 and 9, and just label that. Okay, so that's overjet, the horizontal difference or distance. The overbite is the vertical distance. Okay, if sometimes you have a patient come in and they bite down, then you can't even see their bottom teeth. Their front teeth bite so deep that it covers, you know, their lower front teeth. So that's what we call an overbite. Okay, so if it's greater than normal vertical overlap between the incisal edges of the maxillary central incisals and the mandibular incisors. The normal overbite exists when the maxillary incisors overlap to the incisal third of the mandibular incisors. So you want some overlap, but you know, not 100%. Well, maybe a third. So this would probably be, this is about half. That may be a little bit, you know, over. Ideal would probably be up to here, about a third. But again, the overjet is the horizontal distance from incisal edge to the tooth. And then the overbite is from the incisal edge vertical to wherever it ends. So right there on my chart, I'd probably say 90% overbite on that patient. You can see a little bit of the tooth right here. So maybe 100% on 24 or 25, and 90% on number 8, 9, and 100% on number 10. Open bite, just reverse. Okay, usually the back teeth are hitting, either they were a thumb sucker or just developmental. They ended up where the front teeth, you know, there's a space between their front teeth. So something like that would be an anterior open bite. Cross bite could be on one side, could be on both sides, could be just on the front side, and they kind of crisscross at the premolars. I mean, it could just be one tooth. Okay, it occurs when the maxillary anterior incisor or the posterior buccal cusps are in lingual version turned towards the lingual side and do not overlap the mandibular teeth. Okay, so this would be a crossbite. And a lot of patients function fine like that. You know, if it doesn't bother them and it's not causing any problems, cosmetically they don't mind it, you know, it's up to them if they want to correct it. You know, it could be ideal for them. If they're not breaking their teeth and everything looks fine and they don't mind it, you know, that's their ideal occlusion. But, you know, some patients just, they want to do it. So they end up getting braces and they close it up and reverse it. And that's usually ends up having surgery, either by breaking the jaw and repositioning the jaw and they wire you shut for a few weeks. It could just be on one side. You got a crossbite on the left side and you're okay on the right side. Or I'm sorry, you've got a crossbite on the right side, you're okay on the left side. You see this a lot on kids, where at this point sometimes you want to do a spate or a palatal expander, at age 7, 8, because the roof of their mouth, the suture there, the mid-palatal suture is still cartilage. And if you see this, and you know, in a 6, 7-year-old, and my son, my middle son, my youngest son, had this crossbite, you know, and so he was probably 6 or 7, and we had a palatal expander where we expanded his upper arch. Okay, because it's all cartilage, you can put a little like a little vice appliance there, and every night you click, and it's just spreading it, and then the next night you click, and it's just a little screw that's slowly opening the palate, and then once it opens and crosses over, you let it stay there for like 6 months, and then you take that appliance off. Questions?